The Virginia Cable Telecommunications Association and your local cable provider presents Cable Reports. Join us now as Cable Reports brings you up to date on current issues facing the Commonwealth through discussions with your local legislators and other policymakers from across Virginia.
From the General Assembly and the City of Richmond, I'm Woody Evans for Cable Reports, brought to you by the Virginia Cable Telecommunications Association, connecting Virginians to their government. We're pleased to have with us today Secretary of Health and Human Resources, Bill Hazel. Welcome to the show, sir.
Woody, thank you for having me.
Now, I believe you oversee about 12 agencies, and you have
I think
about
it's only 11.
11, but over 16,000 employees, as I understand.
It's a lot of people.
Great.
Yes, it is.
Well, we have a very important topic I know you wanted to discuss with us today, and it's about opioids. Can you tell us what an opioid is?
Well, opioids are a class of drugs that have typically been used to treat pain, and there are prescription medications ranging from codeine, hydrocodone, OxyContin, on up to morphine and Demerol, and then there are the illegal opioids such as heroin that are out there. And the challenge that we're getting into is over the last few years across the country and in Virginia, we're seeing increasing numbers of people actually dying from overdoses of opioids. And some of that, there are different reasons for it. Some of it's related to increased use and access, and some is the way the drugs are mixed. But right now in Virginia, in the last 2 years, we've seen more people die from opioid overdoses than we have from motor vehicle accidents.
More dying from opioid overdoses than motor vehicle accidents.
Right. Now, I believe that there's a graphic that can be put up which compares 2007 to 2014. And if you look at that, the question is, how could this be? We lost in 2014, I think, 992 Virginians to opioid overdoses. And what's really interesting about that is only about 256 of them were from heroin. The rest of them were from prescription narcotics.
So how did we get to this state of affairs?
Well, it's kind of a long story, and there are a lot of pieces to it. And for those who really want to understand it, I could recommend a book called Dreamland, written by a man named Sam Quinones, who's an investigative reporter for the LA Times. And I did talk to him last year after I read his book. It registered with me because on the prescription side of the house, I lived this. I trained at the Mayo Clinic in orthopedic surgery, finished in 1988, and about that time, the professional world was looking at how do we treat pain more aggressively, and we began to prescribe more opiates in the belief that where relieving pain was important. I mean, well-intentioned, I think, and then pain for hospitals and doctors became the fifth vital signs. It's your respirations, your heart rate, your blood pressure, your temperature, and now your pain. And we were always asked to rate pain, and this little smiley face chart. If you've been to the hospital, ER, they've asked you, and the expectation was once you told us how much pain you had, we would do something about it. There aren't a lot of tools. There weren't. And the expectations we'd manage pain. And then on the other side, in the legitimate medical world of prescription medicine, you would have these Press-Ganey scores, patient customer satisfaction scores. Okay. Nothing makes people unhappier than to leave with pain. So you had these things kind of pushing us into prescribing more pills, I believe. And then I can remember in my practice in the early 90s when I was doing hip and knee replacement and shoulder surgery and so forth, I can remember the drug reps coming in and saying, "Doctor, people will not get addicted if you use these around surgery because it's not a pleasurable experience, and you need that to get addiction." Well, that turns out not to have been true. Wasn't really true then, and it certainly has not been proven to be true. But the long and short of it is we are writing, for really millions of opioid prescriptions. And our colleagues in law enforcement will say, there are just too many pills out there. And what's happened, and I think we're seeing as this epidemic has changed, we used to think of heroin
Yes.
inner cities, somebody else's problem. But now we're seeing it all over Virginia, and I think we have a graphic that can show you the heroin overdoses, deaths, and the prescription drugs. And it's different in different parts of the Commonwealth. Up in the northern Shenandoah Valley, Winchester area, heroin, DC area, heroin, some in Tidewater, heroin, but out in Southwest Virginia, it's pills. And these folks in law enforcement say there are just too many pills on the street and we have to get them. But that tends to be the gateway to addiction. And unfortunately, when you can't get the pills, this is where markets actually work. The OxyContin now on the street, according to the state police, is worth about $1 a milligram. So 60 milligrams is $60, but you can get your heroin fixed for the cost of a six-pack.
Wow.
And chances are you can get it delivered to you.
Delivered to you.
Call a number and somebody will meet you in a car, and you can, in many parts of the country, and you can pick your heroin up and it's near pure.
Now, what about prescription monitoring? I believe the Commonwealth has had a program to monitor prescriptions for some time. Talk to us about why that's significant.
Well, it's critical. We do have the ability now to monitor where people are getting prescriptions filled for opiates. And what amazed me, even in the last couple of years as a physician, was how many individuals are actually doctor shopping, if you will, and maybe filling 10 to 15 prescriptions at different pharmacies. And if you're a physician, you don't know that. You come to me and I take care of you and you're a good man and I trust you, but we don't know what's happened to the pills. We don't know when people are going from one doctor to the other. And so you can check this database and you can find this out. And so one of the things that we've been trying to encourage is physicians to do this. Now, unfortunately, the rate of utilization of the prescription monitoring program has been really low. So there's a bill in this year that would require physicians to check the prescription monitoring program before they write for prescriptions for more than 14 days for opiates.
One of the other things that just amazes me is the number of people who get prescription drugs from their relatives, friends, or neighbors even.
You wouldn't think about it, but I know that last year when we had the task force that started in 2014, Secretary Moran and I co-chaired on opiates and heroin, and it grew out of some work in the prescription monitoring program. So Delegate Hodges was on that. Mm-hmm. Delegate Hodges is a pharmacist, and I'll just give you an example. Pharmacists often, for people in hospice, won't give a full prescription. They'll give a partial prescription. And his experience was that people would come in and fill the remainder of the narcotic prescription after the person died.
After they died?
After they died. So we've tried to tighten that up, but we know in Southwest Virginia, where I've been quite a bit down there with clinics and so forth, that it is not unusual for medications to be stolen. And medication prescriptions often don't get completely used.
Right.
And so there's this problem of leftover medications that sit around that can be taken by someone who probably shouldn't have them.
Now, you mentioned law enforcement. How is law enforcement and healthcare professionals like you and your colleagues working together on this problem?
I think that we're doing a lot. I can tell you it's interesting listening now to police chiefs and sheriffs, and almost to a person, they'll say, we aren't going to be able to arrest our way out of this problem, because police and law enforcement looks for bad guys. They're looking for heroin distributors and so forth. But they're not they're not really equipped to deal with physicians and folks, hospitals where there are legitimate legal practices. And the other thing is when people become addicted, they're addicted. And if you talk to the peer community, a very strong, important role to play in this, the peer community will say of the folks who are addicted, there are two types. There are people who are in recovery or people who are not yet in recovery. And recovery is not really a law enforcement situation. What recovery requires, though, I think, is the carrot of getting better, but also, for instance, in areas where there are drug courts, the ability for the court to say, in lieu of going to jail, you can go into treatment, and it costs less per person, and the outcomes are a lot better.
Now, this is not only a Virginia problem. This is a nationwide problem.
Oh yeah, we had a summit down in Wise last September into September, and we had our colleagues from North Carolina, Tennessee, West Virginia, Kentucky, and Maryland in, and a wide range of federal partners, everybody from SAMHSA, Medicaid, Medicare, law enforcement, the Office of National Coordinator for Drug Control Policy, high-intensity drug trafficking area people. But what was interesting is I called my counterparts around the states, Republicans and Democrats, didn't matter. I mean, this stuff cares nothing about geopolitical boundaries, nothing. And one of the challenges, in fact, that we have is that that because of that, families get into trouble in these in borders. I look at, for instance, Bristol, which is really straddles a border. Say a child is in a family, the leading cause of foster care now around the country is substance abuse. And so your family's in Virginia, but the relative who could take the child is in Tennessee. How do we address these problems? You know, a person, a baby mother lives in Bristol, Virginia, is pregnant, is using the treatment for the baby is likely to be in Tennessee right now. Who takes care of that baby, and how do we pay for it? And actually, I'll tell you, one of the bright spots I've seen in this, there are a couple bright spots in this. One is there's drug courts. And there's a Judge Chip Hurley down in Tazewell, and I've attended 2 of his graduations. And last year, 2 women who were in his program delivered drug-free babies, so he now has 12 drug-free babies.
Oh, wow, that's great.
And this is a problem with these children. I mean, they and the problems they have are with us forever. Another bright spot is Winchester. There's a judge up there, Beth Kellis, the prosecutor there, the sheriff and the county, the police chief, the hospital, and the advocates are working together, and they've got a really good program to divert people from criminal justice, to bring them into treatment. And when you ask the state police what's working, they've pointed to that as an example.
Now, because this is a national problem, I believe President Obama has money in the federal budget for this year to deal with this crisis.
My understanding is that he has put money in the budget that is yet to be enacted. I think it's over $1 billion for things like education, medical assisted treatment, which we probably want to talk about a little bit. But yes, it is something that I think is recognized as a real problem that we need to address.
Well, we'll take a few minutes and talk about medically assisted treatment.
Controversial, it has been, but the challenge we have, and we know that addiction is very difficult. And some people do very well with the 12 steps and the extension programs and so forth, where you just stop and so forth, but there are people who don't. And for those people, there are things like methadone and Suboxone, and there are some newer medications that are out that are available that help with the cravings. What you have to realize is that the substance abuse actually changes the brain and changes the way the brain works. And where you can do MRIs and you can look at how the brains function in people who have addiction issues. And it's different, and it takes some time for that to revert to normal, if it ever reverts. And so some people need help. And that help can be in the form of medications, which can be used safely, help reduce the cravings, reduce the urges, and allows people to be more functional while they're going through treatment. And we know that with medic-assisted treatment that the rate of recidivism goes down. Now the challenge is, and I think where the hard part is that some of these drugs, as some people say, well, you're replacing one addiction with another. And I don't think we're at the point yet where we really, in Virginia at least, have the standard protocols and best practices that we need. How do we wean people off, and what is an acceptable level of support? And that becomes real important if you're dealing, say, with the drug court, where there is some mandate, and these substances can be abused as well. So, but they do work.
Now, what kind of public outreach and educational efforts are required to deal with this issue?
Yeah, I think there's a lot. I think first, for better or worse, we do have all these people who are now addicted, and some are in recovery and some are not yet in recovery. And the nature of addiction is something that we tend to think of as lifelong. So public needs to understand that we have good people who have had issues with addiction that should not disqualify them from employment and housing and so forth, that allows them to live in the community. We just can't say you're an addict, go off and be locked up in either in prison or in some sort of facility. And the challenge of re-entering society, so to speak, and getting employed is difficult. So one of the first things we do is when you go for a job, you get a background check, right? Doesn't work so well if you've got records and issues. So those are things we have to overcome. Another thing I think is out there is that the fact that we have the prescription medications, and people I think tend to think maybe they're just safe because they're prescribed by doctors, but they're safe when used as prescribed, used appropriately, but they may not be safe in the wrong hands. And we really need to think about these opiates differently. We need to think about how we manage pain differently, and how there's pain and suffering, and the two are not necessarily correlated. Right. And so we've really got to think about addressing that. I think it also culturally just cannot be acceptable just to take a pill.
Now you mentioned the importance of drug courts, treatment alternatives. What are some of the economic impacts of this crisis, the significant uptick in the use of opioids and heroin?
Well, it's on multiple levels. I've heard of companies trying to start businesses where they can't hire employees because they fail drug tests. So at a very basic level, people are failing drug tests in certain areas of the Commonwealth that prevent employment. Makes it hard. I've heard of restaurant starts being delayed, trying to find wait staff that's drug-free. So you've got that very basic level. When you start getting into sort of the issues, the health issues that accompany it, the comorbidities between mental illness, one of the big problems now with heroin use and the intravenous drugs is hepatitis. Oh. Hepatitis is a very, very big problem when people are using IV drugs. There was an outbreak in Indiana, for instance. Shared needles, things like that, spread these. And we know now the new best of class medications to treat hepatitis are basically $90-some thousand for an episode of treatment. That's a lot of money, and since most people who are in this situation are not covered by health insurance, not employed, someone's got to pick that up or the epidemic spreads. So that's an economic consequence. Medic-assisted treatment does work. We know with the drug courts, I think that the average cost for someone who's gone through the drug court system now is $17,000, $18,000 a year. It's about $20,000 less than what would happen if they were incarcerated. So there's some good news on that side.
And I saw some numbers recently that suggest for every dollar invested in dealing with this problem, there's a $7 return in terms of the criminal justice system. If you add the other health effects, I think there's a $12 return.
Yeah, I think one of the things that's interesting is just looking across the field that I have in Health and Human Resources. We really are looking, and across the country, both Republicans and Democrats now are looking at this issue of keeping people in jail. And so we look at the issues. If you are in addiction, have an addiction issue, jail may detox you, but it's not treating you. And then when you go back out, you risk it coming back in again, and this vicious cycle occurs. And so we really have to think a little bit more about how we intervene early to avoid the jailing of people who have really medical conditions that need to be addressed. So that's one thing. And then because often these problems co-occur with mental illness and health problems, it does leave us in a situation where we have folks in jails that just can't get the treatment they need.
Now you mentioned some legislative efforts here in the General Assembly, Delegate Hodges, but there are other members. Oh, yeah. For example, Dr. John O'Bannon, who you know very well.
Dr. O'Bannon, good friend, yeah. Dr. O'Bannon has some bills this year. The other two legislators that were on our task force were Delegate Herring and Senator Wexton. And there are a number of bills. So first of all, budget. We think of bills, but budget's
Right.
important.
Right.
So what we really are working towards is having a treatment program for people with substance use through Medicaid, because a lot of folks are uninsured. They fall through the coverage gap, and they're there, and there are no resources for treatment. So getting that right is one thing. Another is figuring out how to better engage peers in the treatment. We've seen a lot of activity here in Richmond, for instance, of the peer community helping, and they do offer good, strong services that will benefit a lot of people. And if you've not met a peer, you should. It's a powerful experience. So I would recommend that. The other things that we have out there, for instance, requiring use of the physician monitoring program. I think it's important. We have another bill that will require some medical education for physicians who prescribe opiates. There would be some rules set up, and physicians who are prescribing certain amounts would need to be updated on the current standards of treatment and so forth. We have bills related to needle exchange in emergencies. For instance, I mentioned the Indiana experience earlier, where you actually had an epidemic. And one of the ways to prevent that is, since not everyone can go cold turkey immediately, you need to have a way to mitigate harm in select situations. So we've got a very narrowly constructed bill to help with that. So there are several others. Reporting to the PMP when a pharmacist does prescribe or does dispense, reporting that prescription has been filled, so it shows up more quickly, so when the next person checks, you know it's there. So those are a few of the bills that are out there right now.
How has the legislation which allows the use of naloxone helped the situation?
I think it's early, because legislation that went in last year went into effect in July, so I don't have a full year's worth of data to talk about it. But what we have tried to do is make naloxone. Now, for those who don't know, naloxone can reverse the effects of opiates. So someone who has had an overdose can get the naloxone and can recover from the overdose if given very quickly. It works very well. It doesn't treat the addiction,
right,
but it reduces the likelihood of death. So the bill that there was legislation, some funding for naloxone and naloxone training for officers and so forth. We know that it's rolling out. Well, I think it's too early yet to say how much of an effect it's had.
So law enforcement is now empowered to administer that antidote, so to speak.
If they choose, yes. Yes, there's not a law that says they have to,
right.
but that they can.
Right. Now, obviously, Governor McAuliffe has been engaged in this issue. I think it was in 2014 that he issued an Executive Order 29, which created a task force that you and believe Secretary Moran have chaired.
Correct.
There were a number of topics that were delegated for study. Let's talk about a few of those. I know we've kind of talked about them, but we can go through those again. Education, we've talked about a little bit.
Both
what were some of the
public education and physician education, the two parts, and I think we have talked a little bit about that. Really important for physicians who are prescribing to understand the science, and for those of us who got programmed along the way that this was okay, and need to think about that. So that, I think we're following through. Public education, probably the biggest thing on what we're working on with Winchester is writing up their activity as a case study, so that community activity around reducing both opiate use and opiate harm can be exported around the Commonwealth, reproduced.
It's a little bit about this new concept on job creation, Go Virginia, that's being discussed. More regional cooperation in order to solve problems.
One would think. One would think.
Another area of study, of course, was treatment.
Treatment, yes. Where we really came down is we discussed a lot around what do we do with people who are addicted and not yet in recovery. And the fact is the group did recommend and endorse medically assisted treatment as an important piece of this. And that is one thing we have done. We are working and looking at how we can better manage the medically assisted treatment, the Suboxone protocols I mentioned earlier,
Right.
and so forth, because we really don't want to get in a situation where we're replacing one problem with another.
Storage and disposal. One thing I've often wondered about, if I have not completed a prescription drug protocol and it's a year old, how do I best get rid of it, for example?
That's an interesting problem. Most of these medications, and this is not just for opiates, this is all medications, most of them need to be incinerated. And the only incinerator for this in Virginia is up in Alexandria. And so what has happened is we have around the feds have sponsored drug take-back days. Mm-hmm. That's one option. The DEA helps with that. CVS has made available drug take-back boxes that communities can put. But the problem you have is if you're the sheriff, that's where it generally ends up.
Right.
They end up with this pile of medications that then they have to transport to some distant site to incinerate. So that is a challenge we're working through right now on trying to find more convenient ways to collect and destroy unused medications of all types.
And of course, collecting data, analyzing it, and monitoring was another charge, and there were recommendations made.
We had a group that met, DCJS led this effort, but where state police, corrections, health, Medicaid, behavioral health, juvenile justice, it's a long list, I've forgotten somebody, have sat down and they went through a process, and we look at what information we actually have. And you can see, you saw some of the slides, you saw the motor vehicle accident slide, you saw the map of Virginia, what's happening where, but we can compare notes about arrest rates, burglaries fund illicit substance abuse use, hospital overdose rates that are not death related, and you can begin to put together patterns of where bad things are happening. And so we're working to use that data to really refine where we intervene. It's, people think about it being a zip code or something, but in some cases you can see around the country where people really look, and you can get this down to a block.
Great.
Yeah.
We got about 30 seconds left, but I want you to make the point you want to make in terms of how do we best address this problem.
Okay. Number one, we have to be attentive to the people who are addicted and are in recovery or not yet in recovery. Number two, got to change the culture. This is something that is dangerous to get involved in, and we need to be sure people understand that. Number three, intervention. Got to get the heroin off and the pills off the street.
Thank you for being here, Mr. Secretary. Thank you for watching Cable Reports, brought to you by the Virginia Cable Telecommunications Association. Until next time, I'm Woody Evans.